I'm going to go, maybe let's see if I can use my camera. Oh, wrong camera.
There you are.
Yeah, but it doesn't, uses my wrong camera.
Okay, let's see. Sorry, guys. Hang on a second. Hi, everyone. Here we go. Just took me a minute to kind of get everything started. So welcome. This is Denise Wilson. I'm your presenter and your host, one of the presenters, and your host today for the AHDAM, Association for Healthcare Denial Appeal Management, for the AHDAM webinar on total joint surgery denials and appeals. And I have DeAnna Fling here with me as well, and I'm going to introduce her in just a minute, and she's going to present some information for you as well today. I think she's going to try to get her camera going, but it didn't look like it was. She was having much luck, so you might just have me to look at today. If you are new to GoToWebinar, there is a little control panel that you can open and close using that little red arrow at the top of the control panel, and you can choose how you want to listen. If you want to do computer audio, call in, or not have any audio. You can also download the handouts from your attendee participation control panel. Go down to where it says handouts, and you should be able to download them from there. Now, if you're having trouble downloading them, which I know sometimes, when you're at work and you're behind firewalls and you're on this, third-party presentation software, sometimes you have trouble downloading. You can go to our website and try downloading them from there. It's www.ahdam.org, and just go to the homepage, scroll down to where you see the title of the webinar for today, which is Total Joint Surgery, and there's a little purple button, I guess, at the top of that area where you can register for today's webinar, and if you click on that, you should be able to download the handouts. So that's the two ways that you can access the handouts for today. We're going to go about probably around 45 minutes with the presentation today, but we do want to leave time at the end to answer your questions. So if you have questions for either DeAnna or for me as we go through the presentation, please submit them in the questions panel, and we will do the best we can to try to get all of those answered at the end of the webinar today. Okay, about the CEUs and the contact hours. So free CEUs are offered to our AHDAM members only. You have to be on this live webinar for at least 50 minutes, and then you have to complete the survey that pops up automatically at the end of the webinar. It's a short survey that you do have to answer some questions in order to get your CEU. The CEU certificates are emailed to you, and they're usually emailed out in about an hour. I don't know where I came up with that at. In about a week. Once we've confirmed, that you've been on for 50 minutes and you've done the survey. They're not available if you're watching a recording of this live webinar. And there's no individuals in a position to control content for this activity that have any financial relationships to declare. From the survey, when you do the survey, like I said, it'll pop up automatically for you. You can select your desired CEUs. You can select as many of them that you need or want. We have them from ACTIS, from NARI, for CCMC for case managers, for AHEMA, and for ANCC for our nurses. Our next complimentary webinar is coming up, I think I put Tuesday, and I hate when I do that. I'm pretty sure December 15th is a Thursday at 2 p.m. Eastern. Excuse me. And our special guest speaker is going to be David Glazer. You may know him if you follow Monitor Monday. He speaks on Monitor Monday pretty much every Monday. And he's also on our advisory board. And so he is going to speak on dispelling widespread misunderstandings of the CMS Two-Midnight Rule. And you can register now. That registration is up on our homepage at AHDAM.org. Again, it's Thursday, December 15th at 2 p.m. We usually try to do them on Wednesday. He wasn't available on a Wednesday, so we're going to do it on Thursday, December 15th. Okay, a little bit about us. We are the nation's only association dedicated to healthcare denial and appeal management, and it's our mission to support and promote those of you who are working in this field, because it really has become kind of a, it's becoming a recognized profession, really, of work that we do for providers. And our vision is to create an even playing field where patients and healthcare providers are successful in persuading medical insurers to make proper payment decisions. And AHDAM was created through the generous support of PayerWatch. I also want to say that most of what we've presented in AHDAM so far, we've been an association for about 2.5 years now. And our focus has mainly been on inpatient, acute care, level of care, clinical validation, some coding issues. And we set a goal for this year to try to expand our offerings to start to include physician offices, outpatient services. And so I was really happy to be able to connect with DeAnna, who is one of our AHDAM members, and she does a lot of education. And she's kind of in, that physician services arena. So I'm just thrilled that she's offered to do some of the presentation today. So I do need to read the disclaimer that AHDAM publishes and distributes materials on our website that's created by our members or invited industry subject matter experts for the benefit of all of our members, but we do not certify the accuracy or authority of those materials. They are distributed and presented as research information to be used by you in conjunction with other research that you deem necessary in the exercise of your independent professional judgment. We claim no liability in relation to reliance on the content of these materials. The views expressed are the views of the materials authors, do not necessarily represent the views of AHDAM. Any references we provide are for informational purposes only. They do not constitute endorsement of any sources. Okay, me, I am Denise Wilson, and I am Senior Vice President at PayerWatch, also known as AppealMasters, and I'm also President of the association. I've been in healthcare for well over 30 years now, and I have been in the appeals world for about 17 years, and I these days do a lot of education, a lot of training, and a lot of support for folks who are working in this denial and appeal management area. Our presenter today, DeAnna Fling, she's revenue cycle educator and operations support for U.S. Oncology Network, McKesson Pharmaceutical Solutions and Services. She has 20 years in combination of clinical and revenue cycle experience in hospital setting and oncology medical practice. She's been writing appeals for 13 years in hospital Part A, hospital outpatient departments in oncology. She has presented cases to the administrative law judge, provided to physicians and billing teams education based on denied services. In her current role of revenue cycle educator for the U.S. Oncology Network, she provides education to insurance follow-up staff on best practices in researching payer policies on denied services and drafting appeal letters to all payers. So I'm going to turn it over to DeAnna and let her talk to us a little bit about total joint surgery.
Thank you, Denise, and thank you for the introduction, and welcome everyone to our presentation. I'm kind of like Denise too. I live here in Texas, and the allergies have really hit all of us pretty hard, so I'm hoping not to get too choked up as I move on. But first, I want to talk about authorizations. I think that this is really a good place for us to start. Post-COVID, obtaining an authorization for services has really gotten complicated. And to add to the complexity of payer medical policies, in order to meet medical necessity, now I'm seeing more commercial payers are outsourcing their authorization work to third-party companies, which, as you know, offers another set of complexity in terms of meeting medical necessity. It becomes even more frustrating when our patients don't tell us about recent changes to their employer-based insurance, or when our senior patients go from traditional Medicare to managed Medicare and vice versa, which is why I stress a lot, verify and check eligibility often to determine your primary and secondary insurance so that you can ensure that you are contacting the correct carrier and using the correct portal and obtaining that authorization. Develop within your team a cadence to verify insurances up to the time of surgery to ensure that benefits are coordinated between the two and that you have that correct authorization on file. Now, while most of our insurers follow the CMS guidelines, especially our managed Medicare plans, insurances with PPO and HMO plans may vary on how they follow CMS guidance and they choose to modify their policy on meeting medical necessity. So be careful of the policies that you are viewing. And then last of all, communication is key to obtaining an authorization, especially with the clinical teams, which could include the orthopedist office. Most insurances now provide several levels of appeal rights at the point of authorization, with the opportunity to conduct a peer-to-peer review. Next slide, please. Now let's talk about the medical records and what medical records we are going to submit at the time of the auth request. Based upon the payer guidelines, to meet medical necessity will be the driver as to what medical records you will need to submit. Documented failed modalities and treatments from various physicians at different specialty levels are important documents to submit, as well as DME notes, imaging records that show evidence of advanced joint disease, as well as documented physical exams, especially from the orthopedic surgeon. Next slide, please. So now let's move on to CMS guidance. CMS created an MLN dated 2020, which is the most current synopsis of the CMS guidance that we have available to us. The consult note provided by the orthopedic surgeon needs to be a very detailed description of the timeline of the patient's advancing joint disease. What is especially important are the ADLs, failed drug treatments and modalities, such as instability with use of a cane, having to use a walker, or worse yet, using leg braces, and hopefully your physician, the orthopedic, has documented which type of braces the patient is using, and whether or not the patient is wheelchair confinement. Now, if the physician did order PT, it needs to be documented what kind of treatment plan the patient is under. Documented PT visits should include changes in range of motion and frequency of the PT services themselves. I highly encourage that you submit these documents with your auth request if they are obtainable. Same for weight loss programs, whether they be scripted to a professional weight loss medical group or if it's an OTC program such as Atkins or a Weight Watchers program. Next slide, please. So also found in the consult note is the physical exam. Now, while all of these are important, I did find when developing appeals, my MAC wanted the range of motion documented and how pain management alternatives with PT did not improve the range of motion. If crepitus is documented in the consult note, it should also be documented in your appeal letter. And then, of course, physicians should document the patient's gait. Again, imaging is important because it shows advanced joint disease. It's also good to remind your physicians that in the consult note, they should be documenting any comorbidities that will impact the patient's joint health or the outcomes post-surgery, whether that be a comorbidity. If the physician feels that the patient cannot warrant through separate failed treatment plans, there needs to be a clinical statement as to why the physician has chosen not to use a step care approach to treating their patient. Next slide, please. So as we're moving forward now, we're up to the pre-op note, and this is going to be a summary of the consult note, but this is where you should also find a list of diagnoses and possibly diagnosis codes, depending on the physician and then also to the hospital EMR that are going to be applicable to the timeline of the patient's joint disease and what led up to the patient's need for that procedure. So this list is a list of the applicable CMS diagnoses. It's important to have the physician document the severity of osteoporosis, the severity of the malignancy of the skeleton, if the patient is in reoccurrence or in relapse, or is this a new diagnosis? Type of fractures is also important, such as hairline versus complete break. So if you are appealing, whether it be because your authorization was denied or your claim was denied from the payer, this level of detail you will need to find somewhere embedded in the consult note or the office visit note to add to your appeal letter. Next slide, please. And as you gather your medical records for your appeal packet, you will also need to include these 3 documents as they are very much important as well. It will show the medical reviewer that the billed CPT procedures were actually done based upon the surgical needs of the patient's condition. The daily progress notes will show that the patient is coming along with wound healing, response to the surgery on the patient's comorbidities, and then of course taking those first steps out of bed to walk around the room and also to go to the bathroom. The discharge summary will provide the medical reviewer with an overview of the patient's advanced joint deterioration, review of the procedures performed, any post-discharge orders such as PT, DME, and or pain management. Next, please. So let's move on now to what we need to do once the business office has received a denial for the joint service that the physician has performed. We can challenge a denied joint replacement surgery in several different ways, but the most strategic method of challenging a denied joint replacement surgery is to focus on the extenuating circumstances that prevent the patient from successfully participating in or completing a trial of conservative therapy. And while explaining how medical necessity was met based upon a payer policy and the fact that you do have an authorization on file, those extenuating circumstances allowed for a failed therapy is what you're going to be focusing on and what is going to be the key to overturning your denial. You should develop a timeline of events if the joint surgery is around a recent past injury, but if the advanced joint disease is due to a past injury, again, failed therapeutic treatments and any other extenuating circumstances that led to the patient not being able to comply or to fail conservative treatment should be documented in your appeal letter. If the patient's hospital stay was denied and it was not related to the need for joint replacement surgery, but rather to an extenuating circumstance regarding a comorbidity, you will need to find evidence in the medical record that allows you to challenge the denial based on medical necessity or standard of care measures. What should not be mentioned in the documentation by the physician is the need for only satisfying the desire of the patient to have that surgery. And then lastly, in your appeal letter, you should always be either quoting directly from a payer medical policy or summarizing the policy itself. Even if you feel your challenge to the denial is weak, you always need to write about the medical policy. And in those instances, it would be best to also quote or summarize from another additional medical resource, such as Interqual or MCG. So thank you, Denise, for letting me present. I will turn the rest over to you.
Okay, thanks. So let me talk about a couple things, just kind of expand on what DeAnna was talking about. And someone just asked about, talking about inpatient, and that's what I'm going to talk about for the next few minutes is inpatient versus outpatient when you get denials for that. So besides looking at the payers' published clinical guideline or their clinical, I can't think of the word I want to say, their policy, clinical policy for payment for joint surgeries, you can also look at what is the standard of care from the medical societies that are involved in these types of surgeries. But my experience has been when I look at a commercial payer's clinical policy about what they will and won't cover as far as, for example, the joint surgeries, they create those policies based off of standards of care. And if you look, you can look at any payer's policy and look at their references at the bottom of their document, and it'll tell you what all published peer-reviewed journal articles they use to come up with the requirements for payment for this particular procedure, because obviously, the payment is going to be based on whether that surgery was medically necessary or not, whether any service is medically necessary or not, and whether it's appropriate for that patient. So when it comes to appealing services that are covered by a policy bulletin or covered for Medicare, we talk about NCDs and LCDs. What I found is, for the most part, they're typically up to date as far as following what the standard of care is. At least, let me say, for the commercial payers. I have on occasion, rare occasion, found an LCD or an NCD that I felt that hadn't been updated for a while, that I felt did not reflect current standards of care. And so that's always an option for appeal when you run into those types of situations. I went through, I searched through a lot of appeals that I happen to have access to come up with some examples for y'all today, because I know you like to see real case examples. And I was not having good luck finding denials for the medical necessity of the joint. I know that I have seen some, and I've seen some appeals for that. I just couldn't find one that I thought was a good example to share with you. But I think what DeAnna talked about as far as extenuating circumstances that prevents them from successfully participating in conservative therapy, that's the biggest issue that I see as far as denials. Is they say, well, you didn't put the patient through all of these paces. You didn't put them through their paces to determine that conservative therapy wasn't going to be beneficial to the patient. You know, you jumped too quickly to just deciding that you're going to do joint replacement surgery. So I see that a lot. And that's when you really want to look for what are those extenuating circumstances that, you know, sometimes patients cannot complete a trial of conservative therapy for various reasons, or they don't tolerate pain medicine. They don't tolerate physical therapy for some, you know, reason unrelated to their joint disease. So that's really a place to look for that. The other things that we used to see years ago, and I think this has been cleaned up quite a bit, is not having all of the outpatient physician office notes sent to the payer in preparation for to get authorization for the surgery, like the you know, the x-rays might not be in there. Or I've also seen some payers who want to see the actual physical therapy notes, which, you know, some payers will accept what the physician has said in the record. Some payers will accept the physician's interpretation of the x-rays, and some payers will be very stingy about that and say they want to actually see the physical therapy notes, or they actually want to see the radiology report from the radiologist. So those are just some things from my experience as far as doing joint surgeries. So let's talk a little bit about inpatient and outpatient, because that question still comes up. And it hasn't been that long since total hips were removed from the inpatient-only list. They were removed in 2020. And in 2018, the total knee arthroplasty was removed from the inpatient-only list. So the inpatient-only list is a Medicare list. Commercial payers do not have to follow the list that Medicare publishes, and Medicare Advantage does not have to follow the inpatient-only list. So Medicare every year updates and republishes an inpatient-only list that says they feel that it's safer for a patient to have a particular type of surgery in the hospital in an inpatient status. Okay, so the inpatient-only list really came out as a form of patient safety to make sure we weren't doing procedures in off hospital campuses where there might not be the same resources available should a untoward event occur, or patients or procedures and surgeries that require extensive recoveries, things like that. It was really for patient safety. But it's also for, you know, payment purposes, because if it's on the inpatient-only list, Medicare expects that you're going to do it and bill for it as an inpatient with an inpatient order. So anyway, total knees, total hips are not on the inpatient-only list anymore. Patient status, meaning should you place them in inpatient, should you bill as inpatient, patient status is governed by the 2-midnight rule for traditional Medicare, with some case-by-case exceptions. Medicare does allow some case-by-case exceptions. Okay, so having said that, if you want to find the inpatient-only list, it's called Addendum E, and I do have the URL, the link where you can go out and find that. It gets updated every year. And so they just posted it. They usually post it, I think, in October, beginning of October, because that's the start of their fiscal year. So it comes out around October or November. They just posted the 2023 one. This is the where you can download the 2022, but I think the 2023 one is on that. You can find it from that link as well. Okay. Now, talking about payer policies. So for traditional Medicare, they publish sometimes payer policies that are called national coverage determinations. So if they publish what's called an NCD or national coverage determination, every traditional Medicare patient in the country is covered by that national coverage determination. So whatever that says as far as what's medically necessary for a particular procedure is how Medicare, traditional Medicare, will pay for it. There's also local coverage determinations, and those are written by the Medicare administrative contractors. Those are the intermediaries in your local area, wherever you are in the country. They write their local coverage determinations of how they will pay for any type of particular procedure, surgeries, and things like that. Medicare Advantage plans must follow NCDs and LCDs. So if it's a Medicare Advantage plan and there's an NCD or an LCD published by traditional Medicare, they need to follow what traditional Medicare says. There is no Medicare national coverage determination for hips and knees, but there are local coverage determinations for hips and knees. Now, I don't know if I didn't research to see if every MAC out there, Medicare Administrative Contractor, has published an LCD for hips and knees, but I think most of them have, because this is a pretty highly audited procedure. It gets audited and denied a lot. So if you don't know what your LCD is, which your traditional Medicare and managed Medicare would be following, you can access what's called the Medicare Coverage Database, or MCD, the CMS MCD, and I gave you the link there where you can look for it. And there's all kinds of ways to search. You can search by, if you know who your Medicare Administrative Contractor is, you can search by that. You can just put in hips, knees, arthroplasty, joint, and find your state, and you can look it up that way. So let me tell you a couple of cases that I've got a few cases here that have to do with inpatient versus outpatient setting for these surgeries, and these are recent, within the last year or two. Okay, so this was a commercial payer. It's a 59-year-old female who had a right total hip, and these were all admitted post-op. So I don't think, hopefully, no one's admitting their hips and knees inpatient preoperatively, because if they need to be inpatient preoperatively in today's world, that typically means they're probably not a very good candidate for the surgery. So if you're bringing them in for a scheduled total hip or total knee, you're probably not making them an inpatient from the get-go. So these were all admitted as inpatients postoperatively. This was a 2-night stay for this particular lady. And what I found was I was honestly a little bit surprised that it didn't seem like the bar was that high to get the denial for the inpatient status overturned. Now, I only have like a couple of payers here that I looked at as I searched through database of denials and appeals to kind of look for some examples for you guys, but see what you think as I go through these. So this lady, when we appealed for an inpatient stay, she was admitted as an inpatient postoperatively. The payer, it got overturned, and the payer said, based upon review of the additional clinical information that we provided, we are approving payment for the services requested because the member had mild hypotension and anemia post-op and required acute intervention with IV fluids and packed red blood cells. So the admission has been approved as an acute level care service. So that doesn't seem to me to be a very high bar to, have to jump over to get inpatient. Like I said, I was a little bit surprised to see that. These other ones are kind of similar as well, though. This is actually the same payer, commercial payer. So this was a 62-year-old female who had a total knee admitted as inpatient post-op. Now, she had a 3-night stay, so I was kind of looking for, the little bit longer stays to see what was going on with these patients that the payer said, okay, they need to be an inpatient post-operatively. So this payer said, based on a review of the additional clinical information, they are approving payment for services because following the total knee replacement, she was found to require close monitoring post-operatively due to a drop in her oxygen saturation level. Given the complexity of the case, it appears very appropriate for acute inpatient level of care. So that was really the only post-op, problem that she had was a drop in her oxygen saturation levels. And I don't have in here how low they got. I don't think they got especially that low. But again, that doesn't seem like that great of a bar to have to get over. What's the other thing I was going to say about that? Oh, the wording was found to require close monitoring. Now, I hate those words. Maybe hate's a strong word. Close monitoring, because I always think close monitoring, like in an appeal letter, I almost never use the word close monitoring, because to me, to a payer, that means monitoring always means observation. And what is close monitoring? Does that mean they're on a continuous pulse ox? That's not that unusual these days to be on a continuous pulse ox. Are they on telemetry? That's not that unusual to be on telemetry anymore these days. What does close monitoring mean? To me, it means, you're doing blood draws every couple hours. You're titrating drips. They're on vasopressors. They're having, a lot of arrhythmias that you're having to monitor and treat. So anyway, I just thought that was a little bit interesting that they said in their decision letter they used the words close monitoring. Okay, and then the third one, and then I've got one more I want to go over in a little bit more detail with you. This was a 70-year-old female, right total hip. She had a 2-night stay admitted as inpatient post-op. So she was experiencing orthostatic hypotension post-op with blood pressures of 73/54 sitting, 93/58 supine. The following day after her surgery, she continued to suffer with orthostatic hypotension and an elevated heart rate, and that was limiting her ability to participate in physical and occupational therapy. And she needed an IV fluid bolus as well. That one, I think, that one kind of makes sense to me, because if they can't participate in starting physical and occupational therapy after a total joint replacement, they're not going to be safe to be discharged for, the next day or that night or whatever. I think most of these patients stay at least one overnight. So this one I felt like was a little bit more what I would expect to see as far as overturn. Okay, and then this one I wanted to talk about in a little bit more detail. And the reason I included this one is because this one actually went to external review. And if you've been on some of our webinars in the past or heard us speak, anyone from AHDAM speak anywhere, we've talked about external review. If you don't know what external review is, we actually did a webinar on it in July of 2021 called The Road to External Review. And you can watch that webinar. There's no charge. You don't have to be a member. You can watch that webinar on our AHDAM website that talks all about what we mean by external review. So external review can mean, I think of it a lot of times with traditional Medicare, because that's kind of where I learned to write appeals with traditional Medicare, is once it gets to an administrative law judge, that's external to the Medicare administrative contractor's appeal process. Now, I know there's one step in between there. You appeal to the MAC, and then you appeal to the QUIC, which is a qualified independent contractor. To me, that's still not exactly outside. I know they're supposed to be independent, still not exactly outside of the internal Medicare appeals process, in my opinion. Once you get to the administrative law judge, now you're under the Department of Health and Human Services. You're not under CMS anymore. to me, that's external review. Now, when we talk about commercial payers, managed Medicare payers, external review is whatever level of appeal goes to an agency that is not the payer. Okay, that's external review. Sometimes you have external review opportunities. Sometimes a lot of states will offer external review. I think almost all states offer it for patients, for medical necessity cases, to go to that they can take it to external review. So you may have to appeal on behalf of the patient in order to be able to go to external review, which is independent of the payer. Some states may offer external review for the provider, where you don't have to appeal on behalf of the patient, that you can take your cases to external review. Most states do not allow, do not consider coding or clinical validation appropriate for going to external review. They think of those more as payment issues rather than or medical necessity issues. In this particular case, this is Blue Cross Blue Shield PPO, and they actually offered, in their appeals process, they offer the opportunity to go to external review. Either the patient can go to external review or the provider can go to external review. Okay, so that's payer policy. So this was so we took this to the external review. We did not appeal on behalf of the patient. We appealed on behalf of the hospital. So this is a 63-year-old male, right total hip arthroplasty. He was admitted post-operatively. Now, he only had a one-night stay, okay, as an inpatient. He had diabetes, obesity, his BMI was 30, and hypertension. And like I said, this was a PPO from Blue Cross and Blue Shield. So this, to me, it was actually a fairly weak case. And I was very surprised that it got overturned at external review, but I just wanted to give it as an example of, if you're not going to external review, why aren't you? Because you may typically have a better chance of getting overturned than you do with the payer themselves. So anyway, the hospital where this was provided, where the service was provided us with a communication that came from Blue Cross and Blue Shield that said, effective September 8, 2021, patients with post-op complications related to the below conditions can be upgraded to an inpatient level care when appropriate and will be reviewed on a case-by-case basis. Okay, so this isn't necessarily strictly for joints. It's for any kind of post-op complication where the patient, had a procedure done as an outpatient. That they can be upgraded to an inpatient if they have things like COPD that's not optimized, heart failure by history, CAD, cirrhosis, end-stage renal disease, diabetes with an HbA1c, hemoglobin A1c, greater than or equal to 7%, or a BMI greater than or equal to 40. Well, this gentleman's BMI was 30, and he did have diabetes. The interesting thing was there was no hemoglobin A1c in the medical record. Now, maybe, his primary care had a record of it. Maybe the surgeon was aware of his hemoglobin A1c being elevated. It was not documented in the medical record, though. His BMI was documented as 30. Now, a lot of times for knees and hips, the payer's policy for joint surgery may have a restriction on the BMI. They may say they don't cover it if the BMI is, above a certain number, okay, because they expect the patient's going to try to lose weight first to try to take some of that stress off of those hips before you go to surgery. But here, Blue Cross Blue Shield said, for surgeries, outpatient surgeries, this is when you can upgrade them to inpatient status, change them to inpatient status. So the only thing that really happened with this particular gentleman is he did have elevated blood glucose readings as high as 328, and of course they adjusted his insulin, did around the clock blood glucose monitoring, which seems to be to me, that's fairly routine post-op care. His attending physician in the record did document the need for the inpatient status, and that was due to his history of diabetes, his elevated A1C, not sure where that came from, and his post-op hyperglycemia. Okay, so this went through 2 levels of appeal internally back to the payer. It was upheld. And then when it went to, that was our appeal argument. This was the denial rationale after we appealed it. They came back and said, well, he had no issues with hemodynamic instability. His medical problems were stable. His blood glucose went up initially post-op. It was controlled with sliding scale insulin. His medical problems seemed to be, stable, optimized going into the surgery. The elevation blood sugars responded to a very simple measure. I like how they said that, a very simple measure of using sliding scale insulin. So observation was appropriate. So it went to external review because the payer let us know in their decision letter, which is great because they don't always let you know that external appeals are available to members with employer group coverage. And so this kind of goes back to what DeAnna was saying, is you got to know what their coverage is, got to know, what their insurance says about different procedures and what needs to be documented for payment. So employer group coverage after the second level of appeal denial, you can go to external review. It's available to members with individual coverage after the first level appeal denial. So after first level is individual coverage, you can go to external if it's group, 2 levels, and then you go to external. This is employer group coverage. That means they'll do a complete reexamination of your case by an independent review organization, and going to external appeal is a voluntary level of appeal, so don't feel like you have to go there, but you can. So it went to Maximus, was the independent review organization that this case went to, and the Maximus physician said that according to the health plan's guidelines, a patient with a complex medical problem would be a legitimate reason to admit a patient after surgery. According to the records provided and established peer-reviewed literature, the member has met the threshold of complex medical problems, and it was medically necessary for the member to have been treated at an inpatient level of care. So kind of interesting going through and seeing these overturns, just interesting to see what's getting paid on appeal and what isn't. Okay, so some takeaway points. And DeAnna, I'll go over yours, but you can pop in and if you want to say anything else. Understand the authorization process. Know the payer requirements to meet medical necessity, and that will vary from payer to payer. Not all payers follow CMS policies, but managed Medicare and traditional Medicare are supposed to follow them. Consider valid concerns that support the post-op inpatient admission, and take advantage of opportunities to go to external review if that's an option for that particular payer in that particular case. Okay, so we've got a good 10 minutes to go through some questions. Just want to thank our support team at the corporate office. They're a great group of animals there. I just love that picture. All right, let me look through some questions here and we'll see what we can answer for you. Okay, we see that Advantage plans refuse to authorize inpatient for a knee or hip despite comorbid conditions and risk for surgery. They essentially state, let us know if there are complications during surgery, and then we will consider inpatient. Many of our joints, despite risk, do end up going home within 24 hours of admit. So should that be inpatient or same-day surgery? So, I mean, that's what I hear and that's what I see as well, is that, and kind of I think what I talked about just a little bit is that it would be very difficult in today's payer market to be able to justify inpatient from the beginning of the admission. like I said, today, inpatient typically means your patient is pretty sick. That's how the payers see it. And so risk, especially, it's really hard to argue risk for inpatient admission, even not considering all inpatient admissions, not just the ones we're talking about surgeries and procedures and things, but even medical admissions, really difficult to get anything overturned if the only thing you're concerned about is risk. So I think that's a pretty common scenario.
Mm-hmm.
Okay, someone else said, we have had denials for joint replacement when the supportive imaging is performed in the physician's office and the radiological findings are integrated into the physician's office note. No separate report as would be when out-of-office imaging is performed. We have explained their circumstance, but continue to get pushback. Have you seen this as well, and any advice? I have seen that as well, where I had someone contact me and ask about whether I felt we would have any success appealing a case where the only radiological findings were the physicians in the physician's office note, because they did in office imaging. And I said, I don't think you're going to be successful with that. You really need to have, a radiology report. And they said, well, we don't, they don't get radiology reports. It's just read by the treating physician. So we went ahead and appealed it, and it got overturned. So that was something, something I learned that, okay, it's probably just as much payer dependent as anything else, whether they would pay for that or not. They used to be very, very strict about having a radiology report, but maybe some of them have eased up a little. Let's see. Someone asked about the total joint being a reoperation or joint replacement for malunion. So I do want to say, when you look at that inpatient only, I think that's what you're asking about, that inpatient only list, total or talking about total joints and total knees coming off the inpatient only list. Other types of joint surgeries may still be on the inpatient only list. So it's very, very important to check to see, compare your CPT codes and see exactly what type of surgery they're planning on doing to see whether it's on the inpatient only list or not. Okay, so we're just talking about a scheduled first time patient's got, severe arthritis and they need a joint replacement, hip or knee. Those are not on the inpatient only list. Other types of surgeries they might do for joints, for knees and hips, might be on the inpatient list. Okay, so why the 3-day stay for the 62-year-old with a drop in oxygen post-op? Why the 3-day stay? I wouldn't think a drop in oxygen unless significant would warrant a 3-day stay. And you're right, I would have to go back and look at the details of that one to see if they were having trouble getting her oxygen back up. I don't think she had any baseline, pulmonary issues, so I'm not sure why she ended up staying 3 days for just a drop in oxygen. Like I said, I was really kind of surprised on some of these. Okay, instead of close monitoring, do you have a recommended phrase for inpatient? I just stay away from close monitoring. If they have, like I said, if they have every 2-hour, blood draws, they have every 2-hour, to me, close monitoring means they've got a intracranial pressure monitor in, or they've got a swan gans in, or they've got, I just feel like that's what payers think is close monitoring these days. So I just leave it out. I just don't ever say it in my appeal letters because I'm just concerned about monitoring being equivalent to observation in the payer's mind. Okay, somebody said external review for Blue Cross Blue Shield via provider costs the hospital money. We were told we had to pay for that external review offered by them, and that is the case sometimes, that it can cost you a fee to take a case to external review. Most of the fees that I've seen have been not that high, like they might be $150 or, you know, sometimes they're as low as $75, things like that. I guess it just depends on the payer, depends on where you're located, you know, what your contract does, things like that. But oftentimes there is a cost associated with external review, but not always. Okay, this one I think we already answered. That one I think we've answered. Oh, somebody said they do have a managed Medicare payer that will allow inpatient auth for joint with ASA scores of 3 or greater. That's awesome. Wow. That's fantastic. Okay. Okay, someone else said they have been denied by Medicare when they're only providing the orthopedics X-ray interpretation and no radiologist interpretation. Yeah, that was my experience as well, but I know there was one that I'm aware of fairly recently where they did get overturned with just the physician, I should say just, but with only the physician's, office physician's interpretation. All right, well, we're right up on the, coming up on the top of the hour. Should these patients be changed to observation or stay until, okay, not sure what you're asking there. So anyway, thanks everyone. I appreciate your participation today. Thank you, DeAnna, so much for your part in the participation. I really appreciated it. Any of you out there are interested in doing a webinar, we're always interested in speakers. If you're interested in joining our advisory board, you can reach out to me as well. Really looking for folks where we can expand into offering more resources for physician offices and outpatient services. It doesn't have to be that. If you want to talk about clinical validation, coding, inpatient, acute care, I'm happy to take your suggestions, and you're volunteering to do webinars in the future, so just let me know. All right, thanks everybody. Make sure you fill out your survey if you're looking for CEUs, and we will see you again in December.